third annual Parkinson's Awareness Day. We're thrilled to be able to be here with you for the next hour and have an exciting program planned. To introduce myself, my name is Marcie Heller. I'm the Senior Vice President for Community and Global Health here at Cooperman Barnabas Medical Center and RWJBarnabas Health. I've been with the system for almost 30 years. I just wanted to go over a few housekeeping items before we begin. Please make sure your cameras are off and you are on mute for the entirety of the event. If you can submit all questions through the chat function on Zoom. Just as a reminder, the chat icon is located on the bottom of your screen. You can enter your message in the chat window. All you have to do is enter and that'll send your message. The format for the event will be, for the first portion, Dr. Rabin will introduce her outstanding medical team and go over all the advancements in the field of Parkinson's disease. And then she will accept a few questions. In the second portion of the event, Mary Arisi will introduce to you the incredible multidisciplinary team here to support you on your Parkinson's journey. And then she will accept a few questions. With that, I'm going to turn it over to Dr. Rabin.
Okay. Hi, everyone. Can everyone hear me? Okay. So thank you, Margie. I'm very happy to be here today on Parkinson's Disease Awareness Day to discuss what's new in Parkinson's. Parkinson's looks a lot different today than it did 60 years ago, before the first FDA approval of the first Parkinson's meds. Before Sinemet was approved in 1975, having PD meant a life of early disability and discomfort. Now there are so many things we can do for Parkinson's patients, thanks to science. And so today we will discuss some of the most recent research. Share my screen. And here we go. Okay. Can everyone see my screen? Thumbs up? Okay.
You put it on slideshow, please.
Okay. So, helping PD patients is a multidisciplinary process. Mary Arisi will discuss the neuro rehab piece after our talk, but this is the medical movement disorder team that most of you will deal with directly at some point. In clinic, you may see either me or Viky Busko. And when you call, on the other end of the phone will be either Maria or Teresa. So now we're all going to introduce ourselves. So I'm Dr. Rabin, as you all know. I'm the medical director. I went to Harvard undergrad and then went to the University of California for medical school. Then I came back to the East Coast, went to Yale for neurology residency and movement disorder fellowship. I was at Atlantic Health for 10 years before coming to Barnabas a little over 1.5 years ago. And I'm very happy to be a part of Cooperman Barnabas Medical Center. Viky.
Hi, my name is Viky, and I'm a nurse practitioner. I have been in this role just a little bit about the year. I've been a registered nurse for over 30 years, and I've been in Barnabas Health from 2005 for 19 years. I share licenses in Ukraine and the United States. I restarted my career here around 2004, and I worked in long-term care facilities. Then I moved on into Barnabas Health Hospice for about 12 years. And from there, I transitioned to outpatient side of the practices of nursing. And I've been in multiple sclerosis center from 2017. And that's where I returned to a graduate school at Felician University and got my master's in science of nursing. And from that, I transitioned again into a different specialty of neurology, which is movement disorders.
Maria.
Hello, my name is Maria Gerstorfer. I'm the registered nurse that works in movement disorders. I was a medical assistant for about 5 years, in that time working with Dr. Rabin in movement disorders. And then I earned my nursing degree and my bachelor's, worked in oncology for about a year. And then I had an opportunity to work with Dr. Rabin again. And movement disorders is something that I absolutely loved it in the time that I worked with her. I was really I loved seeing the impact that we were able to make in patients' lives, and I became very passionate about it. So that's how I got here, and I'm just happy every day working with this great team.
Thank you, Maria. And Teresa?
Hi, my name is Teresa, and I'm the PSR here in Movement Disorder Neurology. And I've been with the system for like about 24 years now, but most of my years I was a pharmacist tech. And then there were changes and I had the opportunity to come work for neurology, which I love. I'm very happy to be here and love my team and love working with the patients. And yeah, I'm learning a lot. And it's very interesting. Happy to be here.
Thank you very much. And now we're going to meet the people that you may not have interacted with before. So we actually have a social worker named Jennifer Moon, and she is on the call today, and she can help figure out solutions with families who are having trouble managing the Parkinson's disease on their own at home. And then there's operations, and what I call the background players. You may not see them, but they're crucial to making our practice run. So Annabella Cunha is our practice manager, and I think she was going to introduce herself.
Hi, I'm Annabella Cunha. I'm the practice administrator for BHMG Movement Disorders. It's a pleasure working with Dr. Rabin and Viky, all the team players that have been mentioned and the patients. I've been in neurology for close to 8-9 years, I believe. I've worked with under Mary during all these years under multiple sclerosis, and now we've taken up, the whole neurology department. It's always a pleasure to help as many patients as we can. We have a wonderful team, and I look forward to meeting you in person.
Thank you, Annabella. And then finally, we have Mary Yerusi. She's the Assistant Vice President for Neuroscience. And you're going to be meeting her right after this, right after our talk. But it really takes a village. It is complicated to run this place and get this, get it going. And this is the village. We do have some other players, but these are the main players. Now on to the presentation. There are a lot of people who come to me in Viky Clinic, and they've asked whether I've heard of this article or that article, and what do I think about this new research? And there's literally thousands of research articles that are published each year. So sometimes I've heard of them, sometimes I haven't. Likewise, it's going to be impossible to cover all the notable articles this year in the next half hour, but we're going to highlight some of them. And these are all articles that have been published since January 2023. So relatively hot off the press. Some of them are actually from last month. So here is an overview of today's talk. And first we'll discuss new research on risk factors associated with developing PD, specifically exposure to toxins in the environment. Next, Viky will discuss a new way to diagnose PD with the skin. Then Viky will discuss exercise as a treatment for Parkinson's, as well as a new treatment that is under FDA review and that we hope will be available in the near future. And finally, I will also research on treating Parkinson's through changing the bacteria in your GI gut. This will be followed by questions, and I think as Marcie pointed out, the questions will go through. Everyone should enter in the chat box, and then we'll go through what we have at the end of the talk. So let's start with environmental exposures. PD is caused by a combination of genes and environment. So people with PD will have genes that put them at risk for developing PD, but they won't develop PD unless they're exposed to certain things like environmental toxins. You cannot have PD without both at play. One alone is not enough. Environmental exposures that have been associated with an increased risk for developing PD include pesticides like rotenone, herbicides like paraquat, and certain solvents like TCE, and certain pollutants in the air. So there's so it's been known for a long time that environmental toxins, that certain ones, not all, will increase your risk of developing PD, but there's been new research on certain environmental toxins. Interestingly, well water use is also a risk factor because it often contains pesticides, herbicides, and solvents. Two important articles that came out last year. One was on air pollution. So the ELAPSE study evaluated the association between the long-term exposure to different types of pollutants in the air with Parkinson's-related mortality. So what is Parkinson's-related mortality? It is defined as having PD listed as one of the underlying causes of death. When doctors are asked to fill out these death certificates, you're asked to list everything that you think contributed. So even if you die of a blood infection, if the doctor thinks that Parkinson's contributed to it, it's going to be listed. Both gaseous pollution and confined particles can damage the brain. And how would it do that? Well, likely through entering your nose. So the nose is one of the most direct routes to your brain. So it goes in your nose and it has contact with the olfactory nerve. And then the olfactory nerve comes directly out of your brain. So in that way, it can affect your brain. So if you're smelling something, it can not only give you respiratory symptoms, it can, there's a reason why it probably can affect your brain. So after it enters the brain, after it enters your olfactory bulb, it crosses the blood-brain barrier, and then could start to damage cause damage. And so that's one of the reasons people with Parkinson's often don't smell well. Based on data pulled from 7 European countries, of 270,000 participants, 381 died from PD-related causes over 19 years of follow-up. And there was a positive association between PD mortality and the average residential fine particulate matter number. So, specifically, so there's little particulates in the air and made of certain substances, and that is what was found to be related. The hazard ratio was 1.25, so meaning if you had a higher fine particulate matter in the air, you're at 25% increase from dying from PD. The authors concluded that exposure to this matter at levels well below the current European Union air pollution limit values may contribute to PD-related mortality. So these are allowed limits, and so it's kind of upsetting when you hear this data, at least it is for me. Next, on to solvents. Trichloroethylene, aka TCE, is a widely used solvent and used for decades and found in many consumer products. It can be found in such things as dry cleaning fluid, furniture repair, spot remover, and even arts and crafts supplies that kids play with. While the chemical is banned in almost 60 countries, it is of course still widely used in the US. In 2023, a study of military veterans was published and demonstrated the strongest evidence yet that the widely used solvent is linked to PD. Between 1975 and 1985, the level of TCE in the water of a military base in North Carolina called Camp Lejeune was 70 times higher than the limit set by the Environmental Protection Agency. And it was found that Camp Lejeune veterans were 70% more likely to develop Parkinson's than service members stationed at another site without high levels of TCE in their drinking water. The U.S. Environmental Protection Agency has proposed banning TCE, but of course it's still legal right now. And the U.S. Department of Veteran Affairs expanded its coverage for veterans with PD who were stationed at Camp Lejeune in that period. So basically, the VA acknowledges that there's a connection, and if you're a vet who's living there and has PD, you can get some benefit from the VA as they're saying it's a result, the PD's result of partly a result of you living there, being exposed there. So now Vicky is going to take you through diagnosis and new ways to diagnose.
So Parkinson's disease is currently diagnosed pretty much by clinical history and exam. And a lot of patients can present clinically and still show inaccurate diagnosis. Accuracy of diagnosis could be confirmed, unfortunately, by autopsy only, by brain biopsy. And it's always better when the diagnosis is made by movement disorder specialist or neurologist. Typically, accuracy of diagnosis also gets better and improves when people present with 5 years of symptoms into the illness. We still, in Parkinson's and research for Parkinson's, still looking for biomarker. Ideally, Parkinson's disease would have a biomarkers, for example, like in multiple sclerosis, where they have imaging biomarkers, where they predict, diagnose, and track disease progression by site, location, number of lesions, and how people respond to medications. So a goal for Parkinson's is to have a biomarker like this that could be accurate, easily accessible, and while it changes as disease progresses, so they can track the response to treatments. So right now, one of the, I'm not sure if it's widely known, but that's the only scan, we call it DAT scan or dopamine transporter scan, is available to diagnose Parkinson's or Parkinson's-like disorders. It's a radionuclear dye. I'm going to try saying it. Dopaflane is injected into the blood, and then it has to take a jump to the brain and attach itself to the dopamine transporters, little particles that sit on the top of dopamine dopamine neurons. And once the data gets accumulated, the head gets scanned for the tracers. And people with Parkinson's disease, for those who are positive, will have an abnormal result. And this abnormal result will mean negative smaller values, saying that there's a smaller signal in part of the brain where terminal portion of the dopamine producing brain cells sit. That's called striatum. The diagnostic sensitivity and specificity of that scan is pretty high. The sensitivity is 98%. That means that tests will be positive in 98% of patients who do have Parkinson's, and also will be negative in 2% of patients who do have Parkinson's. The high specificity of it, again, is 98%, and it means that 2% of people who do not have any Parkinsonian features will have an abnormal test still. Is it perfect diagnostic tool? Probably not. It's not widely available. We do have it in ACC. I'm not sure if everybody knows, you have to stop certain medications before the scan. There's a whole list of them a couple days before the scan. It does not differentiate idiopathic Parkinson's disease from other Parkinson-like syndromes. And it also, the values on it, they don't change over the time and disease progresses. And if you see, you just saw in the picture, there was a brief picture of normal scan. That's a striatum in a healthy a healthy human when it looks like two comma shaped images, and in Parkinson-like syndromes and Parkinson, they kind of present as two commas in the brain in striatum. Very excited to present skin biopsy. There was actually a study came out basically last month in Journal of American Medical Association. It was called Synuclein 1 study. I call it 1, like a little nickname. It shows how skin biopsy can differentiate between patients who have Parkinson's disease and Parkinson's plus syndromes and healthy individuals with actually more than 95% of sensitivity and specificity. So this biopsy is commercially available. According to what we know, it's cheaper and accessible than DAT scan. It's a kit that would be mailed to you. It's available by one of the companies. I think it's C&D Life Science. So procedure is, from what we heard, is pretty simple. It involves a punch biopsy. You can see on the picture, minuscular punch biopsy tool there. It's like a little mini cookie cutter that used in dermatology for ages and also been used in neuromuscular medicine for neural biopsies for many years as well. So that tool goes into the skin, and 3 samples have to be taken from around the shoulder, hip, and leg. And then it goes back to the lab, and where a pathologist needs to look under microscope to look for misfolded protein. In medicine, we call it phosphorylated synuclein. In nerves of skin, they are found in brains of people with Parkinson's disease. The biopsy sizes vary from 2 to 10 millimeters, so I'm not sure which one is that, but I'm hearing that it doesn't require any stitching, and the sample just gets taken out and it goes mailed back to the lab. So what's better, DAT scan or skin biopsy? Skin biopsy seems to be, when it comes to the kit, it's pretty approachable and seems to be a little more cost effective than actual DAT scan. Unlike DAT scan, it can differentiate between Parkinson and vascular Parkinsonism and other Parkinson's plus syndromes. Again, unlike DAT scan, it will probably miss some of the Parkinson-like syndrome, not like DAT scan is. Do you need a skin biopsy? We are actually working on that one. We reached out to the company and we're waiting for them to get back to us. Most people in our clinic get diagnosed clinically, and we can predict the prognosis and diagnosis, but it probably will be very useful early on in disease and to help. And actually, diagnostic accuracy and history of exam will improve over the time. But we will update, once we know more about the test itself, the company. Now on treatments for Parkinson's, where there is a very broad variety, and we kind of divide them into pharmaceutical, which means medication, drugs, and the natural intervention, where there is exercise, another very wild therapy in treatment, and diet and microbiome, and surgical intervention. Very excited to present, not to get ready to go, but there is a subcutaneous infusion. Doesn't have a name. So unfortunately, it's a bunch of letters and number called ABBV 951. The company that's working on it is AbbVie. The medication is based out of the golden standard for Parkinson's disease. That's the main chemical ingredient. It is carbidopa-levodopa. That is well known as a average size yellow tablet that when patients take it over the time and when disease advances, it becomes imperfect solution because a lot of people develop diabetic dyskinesia, meaning they can start feeling symptoms, motor symptoms, especially we call them fluctuations at the end of the dose and at the peak of the dose. We call it wearing off, and there's a lot of people who do not tolerate because of their very specific gastrointestinal tracts, carbidopa, levodopa as the actual medication itself. So the infusion is, you're being told, is subcutaneous. It goes in through a tiny subcutaneous cannula that could be 6 to 9 millimeters, and a catheter can be infused through the pump that you have to carry, portable pump, size of about 2 iPhones, put on the top of each other, and it fits this syringe-sized reservoir of medication in it. It can infuse the drug up to 16 hours a day, and average dose of levodopa could vary from 600 to 4,500 milligrams a day. It's already up in action, approved in the United Kingdom, and their National Institute of Healthcare and Excellence already approved it, I believe it was in end of 2023 or in fall of 2023. So in the United States, phase 3 trials ended. They proposed it to FDA. They looked at it and they asked for more additional information, and it's been under their second review from 6 months ago, and awaiting approval. This medication is known in trials to greatly improve people's motor fluctuations, dyskinesia, and overall any kind of motor symptoms associated with Parkinson's disease. I'm moving on to physical activity and exercise. I will try to pronounce Tai Chi correctly. Tai Chi is an ancient Chinese traditional moves that base itself in martial arts, and it's pretty much is a low impact exercise that is a combo of slow movements and breathing. I believe there's about 108 moves involved in being involved in Tai Chi, and they call it, in different words, they call it meditation in motion or series of fluid motions. So there was a study, in 2024 already. There was a study where they studied about 350 patients, 143 of them did have Parkinson, and they were enrolled in Tai Chi, and about 187 patients were not exercising with Tai Chi, under Tai Chi techniques, and they were, those 143 with Parkinson's were enrolled into our a-week sessions of Tai Chi. They were monitored for about 3.5 years, and study concluded that it was beneficial for patients with Parkinson's disease. Tai Chi training has a long-term benefit on Parkinson's, and especially it improves gait, balance, and cognition. Tai Chi, while we knew there was a studies before, short study, like in the short term, we knew there was a benefit, but now we have a proof from this year that Tai Chi may slow progression in the long-term benefit, give Parkinson's patients. Also, there's been some measures where they concluded that Tai Chi may be possibly suppressing inflammation in brain, like one of the proposed mechanisms that lead to Parkinson's disease through increasing clearance of toxins and normally folded proteins called alpha-synuclein. This is a graph of Parkinson's fluctuations and motor symptoms. So you can see easily in a little black line and figure, you could see patients who were enrolled in Tai Chi. That's the first black column, low compared to the gray column. You could see on dyskinesias that it was a very little numeric value. People with wearing off symptoms were in about same range. People who typically have dystonia and hallucinations didn't have any who were enrolled in Tai Chi, but you could see how high was number compared and those who were not involved in Tai Chi. Also, patients who actually helps people with cognitive impairment. MCI stands for mild cognitive impairment, about the same benefit as dyskinesias and veering off in Tai Chi. And restless leg syndrome has a little higher occurrence, but it's still lower in those who were enrolled into the team than people without those healthy control. A little more about physical activity. So we have a study from before where any kind of physical activity, even a single physical activity, is associated for those who will reduce or lower the Parkinson's disease risk. But when researchers looked at all these studies that were done before, they were more cohort studies. They realized that all these studies were involving men. Now, since last year, there was a study published who is talking about women and the benefit of physical activity for women. So it's been a group of women, about 95,000. I'm not going to go into exact numeric value of what they looked over about 3.5 years, and they looked at them after 17 years. From 95,000 of women, 1,000 and tiny bit develop Parkinson's disease. The women, they grouped them into different physical activity, and they were light cleaning, heavy cleaning, any kind of housework, cooking, walking, stair climbing, rigorous and moderate recreation activities, sports, cycling, and gardening. So they concluded that for women, this risk decreased with increasing level of physical activity. So these results are now added new to additional studies that we had about men. This is a new studies in women.
So thank you, Vicky. So finally, we're going to talk about the gut microbiome. So the gut microbiome, that's the bacteria that lives in your gut. Everyone has, I know, thousands of bacteria in their gut. And that's why some people take probiotics, which is good bacteria, more good bacteria. So in PD, a protein called alpha-synuclein misfolds and clumps together. Then it goes on to damage dopamine cells in the brain, which typically leads to the typical symptoms. So the protein clumps are likely formed in the gut wall early in the disease course, from which they reach the brain cells via a nerve called the vagus nerve, and it connects the GI tract up to the brain. And this process can be influenced by gut bacteria. Patients with Parkinson's often have altered gut microbiome, so a different type of bacteria living in their gut compared to healthy individuals without PD. And they often show more intestinal inflammation and a destructive intestinal barrier. In fact, really interesting, tremor predominant PD patients tend to have a different type of bacteria in their gut compared to people with Parkinson's without much tremor.
Dr. Rabin, do you want to move to the next slide, because you're still on physical activity, and then we have one more slide and then we'll have to take questions.
Yes, I'm having trouble with the last slide. So this is actually the last slide.
Okay.
So apologize for that. So researchers ran a trial called Gut Perfect. It studied whether fecal microbiota transplantation, meaning isolating bacteria from a healthy volunteer's species, improves symptoms of Parkinson's. So 46 patients were recruited. All of them had early stage Parkinson's disease, and the isolated good bacteria was transferred to half of the participants with Parkinson's disease. After 12 months, the actively treated group showed significantly more improvement in motor symptoms compared to the placebo group. And there was, in one rating scale, there was 5.8 points in the ones who received the good bacteria versus 2.7 placebo. And the findings demonstrate an important connection between the brain and gut that could influence the disease process and progression. And this is really an area that is being looked at for the future to see what is it about these good bacteria that does help seem to help symptoms, and can we isolate the specific molecules and turn them into a drug. So that concludes. I'm going to stop sharing so I can see the chat, and we are happy to hear. We're happy to understand questions, to answer questions. I'm reading the chat box at the same time I'm talking. I see now, we couldn't see it when we were giving the talk, that the audio was unclear. I apologize for that. And I'm not seeing, my goodness, there's no questions. I guess we covered everything well. So if there's no questions, we can move on to the second part of our presentation today. And we will hand it over to Mary.
Mary, so at this time, if you want to share some information about the wonderful neurological support services that are available to the group.
Absolutely. Can everyone hear me okay?
Thank you. Yes.
Excellent. So hello, everyone. Welcome. My name is Mary Yarusi. I am the Assistant Vice President of Neurosciences for Cooperman Barnabas Medical Center. I'm also fortunate enough to have oversight over the neurology practices for the medical group. I myself am a nurse for over 30 years, the last 15 of which have been spent in neurology. I'm a certified MS nurse, so I worked in multiple sclerosis for many years. And I think that's where I continued my love for multidisciplinary care. I think that Cooperman Barnabas Medical Center, even in the 90s, was doing it great. I worked in the burn unit back then, and it does take a village, as Dr. Rabin said earlier. And we have a great village here in the ACC and in this practice. So thank you, Dr. Rabin, for sharing all of the wonderful things you have going on in your practice and for sharing the updates with us. I think it's really important for us to all stay informed as to what's going on, not only the clinicians, but also the patients. So as I kick off this portion of the presentation, I want to give a shout out and acknowledgement to all of you who joined us today. Thank you for entrusting your care to us. And thank you for being engaged and staying on top of the latest developments. It's really important that you're engaged in your care and that your families and your caregivers are as well. So I commend you for that. So thank you. Without further ado, I wanted to go into one thing that has meant a lot to me, and that was the patient interactions I had over the years. I will tell you that I had the absolute privilege of meeting some of the most resilient people in my life from my work. I have had patients inspire me with their persistence to maximize their own health and have been fortunate enough in many cases to be at the front lines of their successes. And I thought that this quote sort of brings that all together. I'll read it now. It says, "In the confrontation between the stream and the rock, the stream always wins, not through strength, but through persistence." And I've seen that countless times with my patients. And I'm sure if I got to know all of you, I would see that as well. You and me together, it's one of Cooperman Barnabas Medical Center's mottos. I mention this because it really does take a village. You're not on this journey alone. We have resources throughout our programming and our practices that are here to help you and your family. And sometimes having those resources is wonderful, but connecting to them can be difficult. I wanted to have a slide specifically dedicated to let you know within our practice of movement disorders at the ACC, we have Maria, who you met earlier, and also Jennifer. Maria is the practice nurse, and Jennifer is a certified social worker. And they are here to help you connect to all the services I'm going to speak to in the next few slides. There'll also be an email with everyone's contact information that's going to be coming out to not only people that registered for this program, but also to the mailing list that we have at the medical center. I think it's really important that you utilize these resources. If you call and you have trouble connecting to any of our programs, please reach out to Maria or Jennifer. They're going to be happy to connect you to care. It's not about just connecting to care. Sometimes it's, have a question about how I'm going to get to places. I have transportation issues, or I have 15 referrals and I don't know which one to start with. That's what these people are here for. Please include them in any questions you have. That's their role. And again, an email will be sent out with everyone's information so that you can connect to the following programs. Function is one of the most important parts of a visit to your healthcare provider, and that's where all of the people in the next few slides are going to come into play. It's a topic, function, that has to be addressed at all of your visits because that's the way you're going to optimize your movements and your strength. A quote that I pulled from a research article on the NIH website sets the expectation for your healthcare team, and it is imperative that you and your care partners advocate and address this at your visits. The quote says, an assessment of functional status for rehabilitation in patients with Parkinson's disease is recommended at the time of diagnosis and every 3 to 6 months for those of you who are receiving rehab services, and every 6 to 12 months for those who are not. So this is something that needs to be talked about, whether it's your neurologist, your movement disorder specialist, or any of the rehab professionals that you meet. You want to be assessed regularly, and you want to know how you're doing. Okay, here they are. This is the team that makes the magic happen at 200 South Orange Avenue. This is our team of rehab professionals, and all of them possess unique skills and training that can help you on your journey. They work with patients with Parkinson's and other neurological disorders, and I can say, having met each of these people, they're very unique and specialized in what they're able to do. Our physical therapists, here you see Eugene, Blanca, Ashley, and Melissa. They're a crucial part of any patient's care plan. We have a saying in neuro, and that is keep moving. So moving safely, building strength, flexibility, and decreasing pain. That is what our physical therapists bring to the table, and they are exceptional. Occupational therapy, we have Dory and Alyssa here. Our OT team, I can tell you this is one creative bunch. They recently held an impact clinic that is actually still going on. And some of the games that they played and what they brought to the table were really fantastic. And it's something that we're going to continue to support not only in the MS Center, but throughout the neurosciences. For occupational therapy, they also focus on function and breaking through any of the barriers that we have with function. So they create compensatory strategies that will decrease any hurdles that you're having, or at least mitigate them to the degree that they can. And they get very unique and creative in their styles. So definitely someone that you want to meet, these two ladies. Speech therapy, we have over here Lisa, Catherine, and Marilyn. They're from the Voice and Swallowing Center. This group of trained clinicians can help patients with speech, swallowing, and cognitive challenges. This could be anything from difficulty chewing and swallowing, stuttering, hoarseness. Both the occupational therapy and the speech therapy teams are also adept in working with cognitive disabilities. So certainly they can help through that with the proper referrals from your neurologist and your practitioners. They can also help not only with movement, but with cognitive issues as well. And this is Lorenzo. So I don't know if many of you know Lorenzo. I bet many of you do. Lorenzo is also at 200 South Orange Avenue. Lorenzo was the movement that brought Rocksteady Boxing to the ACC. I can't say enough about his commitment to this program. He became a certified Rocksteady boxing coach in 2017. He's worked with us since 2015. His role in the Rocksteady program is to improve the strength, coordination, and balance, and mental focus. For our patients, I hear he's also dabbling in ping pong up there. There's certain new research that shows that ping pong is something that can also be effective in our patients. Criteria for entry to his programs is definitely something that you have to speak to with your movement disorder specialist or your neurologist. And that goes with, all of our programs. You want to make sure that when you're going into rehab, PT, OT, speech, any of these programs, you clear it with your healthcare provider. I'm sure they're going to advocate for much of it, but keeping those lines of communication open, that's what a multidisciplinary team does. We all give feedback. Many of us meet monthly. Our PTOT and speech teams meet monthly with our clinicians so that we know how people are doing and we break through any of the challenges that they're seeing. So keeping everyone informed is really, really important. Lorenzo is at the ACC, and again, that's another phone number that's going to be emailed out with the list that comes out in the email blast. So I suggest you check Lorenzo out. He's pretty special. At the JCC, which is over in West Orange, we have Lorena Tellius. She's a certified personal trainer. Again, many of you may know Lorena. She's been doing virtual exercise programs for some time now. She is moving to in-person sessions as of May 1st. If you want to register for those classes, again, we'll be sending out that mailing, so I encourage you to do it. Her classes are going to focus on strengthening tone and flexibility. So again, another resource that we have from Cooperman and another real champion for our patients. This is Mary Ann. I have heard such remarkable things about Mary Ann and the support groups that she offers. Mary Ann holds a patient support group twice a month. She also holds a caregiver support group twice a month and an early onset support group for early stage Parkinson's the first Tuesday of every month. Mary Ann is a licensed social worker. She's worked with with the medical center for several years now, and her number is on the screen, but it will also be emailed out to everyone. So it's really important that you know that there, again, is support out there, whether it's for yourself, your caregivers, but talking through these things is super helpful for everyone. And again, connecting the team. This is all one big team that's here to support you. So know that, reach out. If you have questions about any of the program, you're going to see Maria and Jennifer's name there. They can help answer them. But please keep in touch with us. Let us know how you're doing and stay on top of your caregivers and make sure that they're always addressing your function and your mobility is top of mind at your visits. With that, I'm going to open it up for questions. And again, thank you for entrusting your care to all of us. It really means a lot. We want to do the best that we can for all of our patients, and we want to make sure that we stay on top of your needs. I'm going to stop sharing so I can see the chat.
Mary, do you want to introduce Carol as well?
I do. I also want to let you know that on this call, everyone, I have Carol Andreo. I also have Lorenzo. So some of Carol Andreo is the director of rehab. So she oversees PT, OT, and speech at the ACC. Lorenzo, again, I mentioned him. He's our Rock Steady coach. So please, if you have questions for them about their programs, please reach out or send something in the chat and let's clarify any questions you may have about the individual programs we just spoke about.
I have a question, or there's a question I think a lot of people might be thinking that I wanted to ask Lorenzo, if he could unmute himself. For patients who are wheelchair bound or just not steady on their feet, are you able to accommodate those patients so they can be included in boxing?
Yes, absolutely. So we do have seated sessions, or at least sessions where majority of our participants are doing it from a seated position. We also offer like virtual sessions. So for those that do have some transportation issues or have some mobility issues, you're able to work out with us in the comfort of your own home. The only things that you really need for like our virtual sessions is a computer or smartphone or device that you can see us, but then also that we can see you, just to make sure that everyone is doing things safely, and that we can also provide specific, modifications, but then also give you some nice motivation. So yes, we have many different levels for our sessions, from sitting sessions all the way up to our advanced level for people that can do, jumping, hopping, and that sort of stuff as well.
And how many classes? I know there's each one's a different type for a different target audience, but how many sessions do you have a week in general overall?
Yes, so for all of our sessions, we have at minimum 2 per level, and then we also have them for virtual and in person. So for like our lower levels, we have 4 sessions available from like our sitting positions for our virtual and in person. And then for our intermediate level, we have 4 sessions, and our advanced level, we also have 4 in-person sessions. And then we also have a whole library of video recordings and things to do on your own. So there is always the ability to watch one of our videos, or at least do anything whenever it's convenient for you as well.
Sounds great.
Yeah.
We're busy.
Carol,
Yes, I just want to say one thing. One of the things that I want to bring up is that we have therapists who are LSVT certified as well as power certified, which are movement programs that emphasize the larger body movements that can help eventually with the smaller movements that patients with Parkinson's end up developing. We have it both in speech, OT, and PT.
I was going to put you on the spot, Carol, to say just that. I think they're wonderful programs, and I think that they're definitely the LSVT Loud especially has shown a lot of great success for Elisa and her team. So, thanks for mentioning them.
Yes, no, they're definitely good programs for both speech and for OT and PT.
Are there any questions that you want to put in the chat? While we have all these talented individuals here.
While people are thinking about that, I hope that there's going to be a presence at the Unity Walk, April 27th in New York. I will be there. Vicky is going to join me, I know so far, right? Vicky, you and I are walking. Last year we had a big team from PT that joined us, so that was inspiring. My daughter comes out for the day, so hopefully we see many of you there. They did a great rock steady training session at there, so we learned a lot about that. So it's really a wonderful event, and I'd love to meet some of you if you're going to be there. Vicky and I will be there, sporting our Barnabas wear, right, Vic?
Okay, so there are no further questions, and no one has anything to ask. I'm going to, first of all, I appreciate everyone that spoke today, that's here. I want to thank you all for attending today's event. Video recording will be made available to you soon for your viewing. A questionnaire will be sent out asking everyone for feedback. We do apologize for the audio, but we do look forward to hearing from you. If you can put, Dr. Rabin, there's a question in the chat.
Looks like they want to know what they'll experience at their first visit with you.
Well, we will do an intake, the basics, this past medical history for all your whole health history, briefly about things not related to Parkinson's, and then going through your current medications. Then we're going to ask specifics about your Parkinson's disease. So we like to know when was the first symptom, what was it, and when, and who diagnosed you before, what medications have you tried in the past that worked for you, that didn't work for you, what are your current symptoms that are bothersome, are you covered all day long, are there some points in time that you're off, do you have side effects from medications, and what you would like to get out from the visit, and then we'll develop a plan and how to address the issues that are most bothersome to you and go over that with you.
I think she brings up such a wonderful point, Dr. Rabin, and to clarify it, Dr. Rabin is wonderful at making sure she understands the patient's goals during that appointment and what you expect, because it's really important that, it's one thing for us to have an idea of how you want to be treated, but we need to be in line with what your expectations are as well and what really means the most to you. And I think that it was great that you added that in there.
So also, let me add that I think Parkinson's disease has a worse name than it deserves. I think when people walk around, when people who are not familiar with Parkinson's, the public will think of Parkinson's as people that they might see on the street who look really bad, and that's what gets. They have an emotional reaction to it, and so that's what they're going to be thinking about and taking home. Oh, that's what Parkinson's looks like. Well, they're not going to remember if someone has, is well controlled with medications, doing well. They might see someone who looks, really good and say, "Oh yeah, I have Parkinson's," and then you'll say to yourself, You have Parkinson's? Huh, that's strange. Okay. You won't remember it because you don't have an emotional reaction to it like you do if someone looks like they're not in good shape. So our goal is to make you feel as close to normal as possible. A lot of times people walk in here, they're really under medicated. And you know, we just try to make you feel as normal as possible. And I think most people, when they walk out, with that, you know, it could be several sessions, but they are feeling better and living a better life than how they came in and when they first saw us. And I want to also say that I think some of the misperceptions about Parkinson's is that so many people walking around, you know, that some of them don't even have Parkinson's. We've seen they have something related to Parkinson's. Or sometimes people, honestly, with dementia, they don't even have anything Parkinsonian-like, but because they move slowly as part of the psychomotor slowing of dementia, they're misdiagnosed as Parkinson's. And so they're walking around telling people, you know, they were told they had Parkinson's, but really they don't. So, you know, Parkinson's is, in most cases, it's better than most people realize. It's very treatable. People, as long as you tolerate the meds, you should have many good years. And my job is to keep you in work if you're still working and not on disability. So I like to have my patients work and retire at 65 or later.
One other question that came through the chat, Jared wanted to find out more about the ping pong program because he's done that in Bergen County, but not around here.
So, Lorenzo, I'm going to let you speak to that. I think that's a little bit separate. You're starting to incorporate some, if I understand it, into the sessions, but I'll let you speak to it.
Yes, I mean, we are incorporating a little bit of ping pong in with our sessions, but there is a group of our members that do have like a ping pong group that they're a part of. So, I mean, Jared, if that is something that you'd like to join, you know, feel free to contact, and I can send over their contact information because I know they're always looking for you know, extra people to join them. I know that they go to a specific, I think it's like Ping Pong Academy or place where they meet, I think, once a week, and they play some games and do some things with one of their instructors for about an hour and a half or so.
And we can get the information to Jared, correct?
Yes, so you can go ahead and do that.
Okay.
Yeah, I think that the research on ping pong is fascinating. It's definitely something to look into. It's really very interesting to see what it's brought out in a lot of patients. Okay, it does not look like there's other questions. I just want to reiterate that all of the numbers will be. Oh, another question. Go ahead.
There is another question.
Yes. So the question is, so Dr. Rabin, are you saying that with good treatment, life can be somewhat normal? Yes. Absolutely. Let me give you some examples. I have a patient who is a UPS delivery man doing the back-breaking work. And I say back-breaking work because usually these workers end up on disability because of their back. So he was diagnosed, I think in his early 30s, had it very young. And so he is now in his late 40s. He is still delivering packages for UPS. He does not look like, people do not know, he hides, you know, he doesn't want to share that he has Parkinson's. And he just keeps going. I have another gentleman, actually, who's now 62. He's had Parkinson's since I think about 50, and he's still climbing ladders in his job in a warehouse. And he's still, you know, he will do 100 push-ups a day. He does, he will go the jump rope backwards, going around a whole football stadium, the track. So, you know, he's in better shape than me. He kicks my butt. So these are good examples. You know, is it 100%? No, like, but but most patients, we can make a dramatically better life, especially for the first many years. It can get a little trickier later on, but sometimes even people to the very end, they're doing pretty well. And so I think, a lot of people are just, another thing that I've seen is that people are walking around under medicated. How do I know? Because they come to my office under medicated, and then we wake them up with more meds. So I think some providers are just like nervous to go above what the FDA approved, but we just give at movement disorder program, we just give as much as needed, as much as tolerated. And the interesting thing is that people with Parkinson's, even in the 40s, they could have problems with their cognition, even early on, like little things like trouble with fluency, getting the words out, some slowed thinking, trouble concentrating, and generally when we think of like Alzheimer's, dementia, there's not a ton that can be done. I mean, exercise actually helps with cognition, but there's not treatments with dramatic effects, not even one that's like, the ones that are FDA approved, they're more subtle. So with Parkinson's meds, it often helps people's cognition. And so some people were like, they can be zonked and tired. Zonked and tired when their medications are not at the right level. So people who were very dull couldn't drive, they increase their meds, and they're driving 2 hours at a time now. So it's we can give their independence back. And so that's why we love doing treating Parkinson's, because there's so much you can do. There's so much you can make a dramatic difference in people's lives with the treatments that we have, and it feels really good to us to be able to do that.
So thank you, Dr. Rabin. To answer your question about slides, we're happy to send them out to the group. Are there any other questions? If you'd like to put them in the chat, go ahead and do so. I just ask for next year going forward, we've done this both virtually and in person. So if you can just quickly share in the chat before we end this, if you'd like to see this in person or virtually, to do it again next year, to do it virtually, can you just post that in the chat just to do a really quick survey while we're here? We'd appreciate that. And then once again, we just really appreciate you being here and spending the hour with us. And
happy Parkinson's Disease Awareness Day.
And happy Parkinson's Awareness Day. Thank you very, very much. And I hope you enjoyed the hour as well.
I see some waves. Thank you. Bye, everybody.
Thanks, everyone.
Great day.
Take care. Be well.
Yes, stay well.